Welcome back. May I continue?
Yes, you can continue.
All right, sir.
But we can't see your screen. There is a media covering your screen.
Okay.
Converting meeting recording. I think we can minimize that. Yes, okay.
Remove it from here. From here. Remove it. Okay.
Okay, we can continue.
Okay, sir. So unfortunately, the patient is close surgery. The second case I saw was just about 5 days ago. 5-year-old Yoruba primary 5 pupil came in with penetrated abdominal. She was unstable and she was going in shock. She was in respiratory distress. She was severely pale. In fact, she was physically paralyzed. And so we took over the management and created advanced trauma life support protocol. And this is a first moist testing. It was an isolated discourse on the surface of the anterior abdominal wall. This is the moist dressing that we applied over it when we received her, and the surgeons came on board and took over the management of this child. Before she was taken into surgery, we were able to also transfuse her and make sure she was stable before they took her in for surgery. So what are the current trends or future trends that people are looking into presently in various centers worldwide? Laparoscopy is very important. A lot of centers are beginning to use laparoscopy unlike before. Then, of course, interventional radiology. People are big on interventional radiology right now, especially in the axis of Lagos. In Lagos axis, a lot of people are employing the services of interventional radiologists. Then, of course, stem cell therapy comes highly recommended, particularly in more advanced settings. Stem cell therapy is being used. Then, of course, in conclusion, abdominal injuries require the surgeon to pay attention to details, be able to take the decision that will best benefit the patient every step of the way. However, to achieve that, the first on call, that is, the emergency physician or the casualty officer, must first keep the patient alive through prompt and accurate resuscitative measures. Thank you very much for listening. Thank you for your time. Highly appreciated. These are my references.
Thank you very much, Dr. Popoola, for the wonderful presentation.
Thank you, sir.
I think it's a very nice presentation. From the outlook, you had a lot of efforts in bringing up all these slides, and it's well detailed and rich. I'll commend you for the hard work. So it's time we will now entertain comments, questions, and contributions. So I think if any participant has a question, comment, or contribution, you can go ahead so that she answers the question. Any question, comments?
Hello, good morning, sir.
Good morning, Dr. Auzi. Good morning. Yes.
Thank you, Dr. Thank you, Dr. Popoola, for your wonderful presentation. I have some comments and questions. First is when you were in the acute the resuscitation and management of the abdominal injury, your LTLS, you mentioned as the first component, you mentioned the catastrophic hemorrhage. So I'm asking, for exam purposes, when writing such management, are you going to put that as number one, or you're still going to maintain the A, which is the airway, and handle the hemorrhage in circulation? So I believe our chiefs can also guide us whether we are supposed to put the catastrophic hemorrhage as number one item to be looked at. Then also, I think considering the region of the abdomen, more emphasis should have been laid on the breathing aspect also, because they share almost the same. They share the same border. That's both the diaphragm and other chest injuries. So I believe maybe you should have made more emphasis on the B. Then you did not make any mention of adjuncts, especially urinary urethral catheterization, catheterization, of course, and that's also where fast should also fall in. Then also, I think I read somewhere where they said the gold standard for investigation is CT in a stable patient, not really fast, but in an unstable patient, you would want to do fast. Then, but in a stable patient, hemorrhagic, a very stable patient, the gold standard is CT scan of the abdomen. Then now my question: what is the difference between penetrating abdominal injury and perforating abdominal injury? And then can you tell us the regions or the areas where fast accesses? Because ideally, I think we are supposed to be doing fast in the emergency room. So what are the regions that the fast accesses to probably make a diagnosis? Thank you very much.
Thank you so much.
Yes, well done, Dr. Awuzie, for your good questions and comment also. So we'll allow the presenter to answer some of the questions, some of the issues you raised. Okay, you can go on, Dr. Popoola.
Okay, thank you, sir. And thank you, Dr. Awuzie, for those comments. They're well taken. And then the question I will attempt to answer them. Yeah, is catastrophic hemorrhage, should it be number one in taking care of a patient, or when you want to do the ATLS? Well, like I mentioned when I was presenting, this thing is not streamlined. So we have been given airway as number one, breathing number two, circulation number three. But the thing is that you're going to be doing multiple things at once because your target is to keep this patient alive. Now, it is called hemorrhage for a reason. If the patient is coming in catastrophic hemorrhage, meaning overwhelming bleeding, heavy bleeding, that is the first thing you are seeing as the patient is coming. At least with one action, you can try to stop that bleeding. You can quickly package, or you can just devise a means of arresting the bleeding. Then you go immediately to your airway to pick other things to keep the patient alive. That is my own opinion. It is not like it is the standard thing to do, but as a physician, we are trained to know what to do when you are in a situation. You will not be rigid all through because the book says do it this way, then you must do it that way. No, it is a guide. So when the patient presents to you a catastrophic hemorrhage, I think the first thing you do, just try to arrest and quickly do other things along with it. Then with respect to, I think maybe I didn't say it with mouth, but I said it as I was reading through. If you look at the slide,
now the wire be this.
you look at the slide now, this slide I'm projecting, you can see that I mentioned that you should pass a urethral catheter.
Now the new
Very
wire
important
inside
because
here.
you want to monitor your input and your output, and it will also take away pressure from the abdomen. Then concerning fast, the abdominal expansion, it is actually you can do it in the emergency room. You can do it in the emergency room because it's supposed to be handheld and mobile. So it is actually a test that you can do in the abdominal, in the emergency room, not necessarily wheeling the patient to the radiological unit. And though, however, in our setting here, so we always request for fast, but we always wheel the patient to the radiological unit. We don't do it here in the emergency room. You said what's the difference? I can't remember the question again, but I'm thinking that you meant between the blunt abdominal injury and penetrating abdominal injury, which one is more common? It is the blunt abdominal injury that is commoner.
I mean the difference between a blunt abdominal injury and the difference between perforating abdominal injury and penetrating abdominal injury.
Okay.
Then for the fast, what I wanted was the areas that we check, look out for the hemoperitoneum or.
Okay. The areas that we look out for the hemoperitoneum, I think, will be in the parapolygotas, in the I'm not sure they can access the peritoneal space. I think it's one of the drawbacks of the past. Then under the diaphragm, it is stated that it usually misses conditions under the diaphragm. And Chief, maybe you help us throw more light on that. I'm not sure I have the details. Then the penetrating abdominal injury and the perforating abdominal injury. I think the penetrating abdominal injury is when you have maybe like stab wounds from knife, like puncture wounds going into the abdomen. Perforating abdominal injury will be injuries that are of even higher of higher energy that have the capacity to perforate this pus with evisceration, and also when there is avulsion or shattering of some abdominal organs. Thank you, sir. I also need you to throw more light on that one, sir. Thank you, sir.
Okay, thank you very much for your attempts to the questions that were asked. Now, regarding the first question, in the ATLS protocol, the ABCDE of resuscitation, traditionally, you follow the A, B, C sequentially, and there's a reason for that. The A is usually given priority in the ATLS protocol for the primary survey because in a complete airway obstruction, the total lung reserve volume is 1 liter. The brain, the oxygen utilization by the brain is about 250 mils per minute. And of course, if the total lung reserve volume is 1 liter, it takes only 4 minutes for the oxygen reserve of the lungs to be completely exhausted, and the brain will undergo irreversible ischemia, irreversible brain injury, because you have only 4 minutes to clear an airway to keep the patient alive if the airway is obstructed completely. That's why in the ATLS protocol, the airway is given priority. However, with recent advances, these keep getting some modifications. In some catastrophic injuries where you have severe hemorrhage, there is a switch between the airway and the circulation. The circulation will now take precedence over the airway because the time it takes for the patient to exsanguinate is even less than that time it takes for the lung reserve volume to be exhausted. So in such situation, you will give the circulation precedence, but you should always mention the traditional protocol, starting with the airway, breathing, circulation. But in some situations like this, you will give the circulation precedence. Okay, so that is regarding that. Not in some cases, you might not need to be, you might not just strictly adhere to that. Okay, even if there is severe hemorrhage, sometimes the utilization of oxygen also will be impaired because effective circulating blood volume will be compromised. And the overall aim of that effective circulating blood volume is to abate any hypoxia. So that is that regarding the A, B, C, D, E of resuscitation. Then secondly, with regards to the fasts, okay, the fast is actually performed by the trauma surgeon at the emergency, not by the radiologist. Okay. There's a difference between fast and abdominal pelvic ultrasound scan. Okay, the essence of fast is not to evaluate any organ. The essence of fast is just to quantify the intraperitoneal, okay, intra-abdominal bleeding. Not that you use fast to assess the liver for liver laceration, the kidney for kidney laceration, bladder trauma, and all. No. What it does, it assesses the pericardial space for collection, okay, the amount of blood that is collected in the pericardial space, the perihepatic space, the amount of blood that accumulates there, okay, the perisplenic space, the amount of blood, then, and the pelvis. So these are the four areas that traditionally, even though you are having some but traditionally, these are the four areas that the fast assesses. Then, when you assess that, you now quantify the total amount of blood. Is it greater than or less than 200 mils? Okay. If the total amount of blood you quantify is more than 200 mils, that is significant and it will require exploration. Okay, so that is the significance of fast, and you should know it is different from abdominal pelvic ultrasound scan and trauma. Yes, the other comment he raised was regarding CT scan. Of course, for a stable patient, the gold standard for evaluating abdominal injury is the CT scan, because it also grades the injury. All those organ injury scale you see, they are all derived from abdominal CT scan. So this is usually done for stable patients. However, for unstable patients, it is the fast that is actually relevant. In the past, it used to be diagnostic peritoneal lavage, but however, with the advent of fast, which supersedes the DPL, It's even faster and less invasive. It's non-invasive, unlike the DPL that is an invasive method. So I think those are the relevant comments, Dr. Awuzie. I don't know if there's still another comment he raised that has not been
yes,
addressed.
You mentioned the difference between penetrating and perforating abdominal.
I can't hear. You said?
You mentioned the difference between penetrating and perforating abdominal injuries, which I attempted, but I would like to throw more light side, if you don't mind.
I think Awuzie should ask the question again.
Okay.
Awuzie,
Yes, sir. I asked for the difference between penetrating and perforating abdominal injuries.
Okay. These are just pathological terms when describing types of wound. Okay. When you say penetration, it means, okay, you have entry into a hollow viscous by a sharp object. Okay, it enters into a cavity or a hollow viscous. That is a penetrating injury. Okay, but when you say perforation, it means through and through a hollow viscous or a cavity. Okay, so when you say penetrating injury, a sharp object, okay, enters into a hollow viscous or a cavity. While perforation, that sharp object enters into a hollow viscous or a cavity, and there's also an exit point. So it has an entry and exit point. That is the difference generally between a penetration and perforation. But to be more precise, when you are talking about penetrating abdominal injuries, any entry that breaches the peritoneum, okay? Any sharp injury, if you have a sharp object that stabs the abdomen and it is limited within the fascia, it did not breach the peritoneum, it did not gain access into the peritoneal cavity. You don't regard that as a penetrating abdominal injury because you won't explore, you will not do a laparotomy, rather you will do a local wound exploration. Okay, so usually that is for penetrating injury. Now, perforating abdominal injury, usually you can see from the definition of perforation, it's true and true, and this is commoner in gunshot injuries. So gunshot injuries, gunshot wounds are categorized on their own. So gunshot is so significant that it is classified as an injury on its own because it's an injury that can cause penetration, it can cause perforation. So in the classification of wounds, gunshot wound can stand as a classification on its own because of some peculiarities that makes it differ from other types of injury. I think you get the basic concept for penetration and perforation.
Yes, sir. Thank you, sir.
Yes. Any other question, comments, contributions? Any other questions, comments, contributions? Yes.
Sorry, Chief. We have a very bad.
Hello? Hello? Yes?
Kindly forgive me.
No questions? Okay. It appears there are no questions. So let me just give a brief summary, then we can end the meeting. Now, it is important as a take-home message. You know that the early management of abdominal injury determines the outcome of that patient. It is the most important point. It is the point that determines whether the patient survives or the patient dies. So it should involve an aggressive resuscitation. This aggressive resuscitation may even involve taking the patient to theater, which will also be part of the resuscitation. Okay? Emergency surgeries do not require any investigations before exploration of that patient. As the patient is rushed into the emergency room, resuscitation is commenced, which might even proceed to taking the patient into the theater. It is urgent surgeries that give room for stabilization and investigations before patients will be explored. Having known this, you should also know that every attending physician or surgeon must be able to recognize signs, okay, of severe blood loss. Patients going into shock, okay? He must be able to recognize other compromising or life-threatening injuries, not only related to the abdomen. You must be able to identify a multiply injured patient. Because if a patient presents with abdominal injury, with other multiple injuries, the management varies. Okay? And also, after maintaining the physiology, for you to operate the patient in the intraoperative principles, you must be precise. You must really know what you are aiming at, okay? There should be no dilemma. You know what you are going to. For blunt abdominal injury, the first principle is early vascular control or control of hemorrhage. This will be followed by prevention of contamination, okay? Because if there is no prompt and early vascular control, patients might ensanguinate while you are doing other things. And to achieve this, you have to do quadrant packing. After appropriate exposure, which should be a long midline when you are doing laparotomy for trauma. Please, it's a long midline incision, coast to coast. Adequate incision, adequate exposure, okay? Early vascular control by quadrant packing. After you do quadrant packing, you suck excessive blood, remove packing from least area of expected hemorrhage so that you don't miss some other minor injuries, okay? Then when you remove pack from the site of major bleeding, you pay careful attention, okay, to the source so that you secure bleeding. And there are various intraoperative maneuvers which you should go and check because of time for securing intra-abdominal bleeding. After you secure that, you limit contamination, okay, by preventing spread of bowel contents, okay. Then subsequently, you now start talking about correction of anatomy, okay. In some certain case, as the presenter discussed, patient might not withstand any of these, your maneuver. You do what is called a damage control surgery. It is a laparotomy that is carried out by trauma surgeon in order to maintain physiology rather than correction of anatomy. And the ultimate aim is to prevent the triad of death. When you have restored physiology, preventing the triad of death, which is hypothermia, hypocoagulability, and acidosis, you prevent those three triads of death, you can take a patient back for a revisit, okay, after patient has been stabilized, taken to the ICU. Then subsequently, you can take patient back for a review to correct anatomy, okay? And you should also know, in as much as you are correcting the problems, patient is not free from complications they might develop from even your management, okay? Increase intra-abdominal pressure, okay, which will affect normal function of other organs in the abdomen, like reduction of venous return, reduction of urinary output, okay, reduction of glomerular filtration rate, and so many inadvertent injuries also, and so forth. But the ultimate aim or the ultimate goal of the early management of abdominal injury is to keep the patient alive for a definitive surgery. Then blood. This is something that you should hammer on. Sometimes the patient might even be transfused with an uncross-matched blood to save the life of the patient, okay? So let us thank the presenter once more. She really did justice to the topic. I think you should share your slides with the forum so that I think they can go over the presentation. Okay. Thank you everyone for participating. I hope subsequent meetings I'll be part of the group because it's a quite interesting presentation. Thank you very much. Now I'll take my leave. I have my patient already on the table.
Yeah, so thank you very much, sir. We are very, very grateful.
Yes.
Thank you so much. We have learned so much this morning.
Thank you very much.
I will share the slides that I said, but I want to put one more slide with some of the things you have said now. I want to put a slide, then I will share it.
Okay.
Yeah, thank you so much, sir. We are grateful. And Chief Dr. Toba, can we close the presentation? Hello, Chief Dr. Toba. So, thank you so much, everyone.
Yes, we can.
Okay, fine. Thank you, sir. So we are going. Thank you all for joining and have a great day. Bye.